Assalamu alaikum. So today we are going to discuss about a very important clinical and common topic which you see in everyday life. Whether you are a general practitioner, whether you are working in the periphery, you will encounter many cases of this disease. I am talking about malaria. So as you know, malaria is a vector-borne illness. It is transmitted by a parasite which is known as plasmodium. How this plasmodium is transmitted from one person to another? There is a vector which separates this parasite from one person to another, and that is known as female anopheles mosquito. As you can see in this picture, this is a mosquito. This is known as female anopheles mosquito. This female anopheles mosquito transmits parasite from one infected person to the other. So vector is anopheles, parasite is plasmodium, and host is human. In this video, I will mainly discuss on the clinical features and treatment and diagnosis of malaria. But before going into the detail, how a patient with malaria presents, what are the investigations which we should perform in this patient, and how we manage uncomplicated and complicated malaria. First of all, let's briefly discuss the life cycle of plasmodium. This is the life cycle of plasmodium. As you can see here, this is a mosquito which is carrying the plasmodium in its saliva. There are different forms of plasmodium. It is either in the form of sporozoites or merozoites or trophozoites, gametocytes. There are multiple forms. The infected form is known as sporozoites. They are present in the saliva of the Anopheles mosquito. When such mosquito, which contains sporozoites of plasmodium in its saliva, bites a person, it injects its saliva into the blood circulation. So the sporozoites also come into the circulation. These sporozoites then move towards the liver cells. As you can see here, this is the liver. Sporozoites are moving towards the liver. So after injecting sporozoites into the circulation, these sporozoites move to the liver. They are taken up by the liver cells. In the liver cells, they are converted into merozoites. These are known as merozoites. So they are converted into merozoites, and when the liver cells rupture, they release merozoites into the circulation. Now third step is merozoites are released into the circulation. These merozoites then infect circulating red blood cells. Remember, sporozoites cannot infect red blood cells. They are first converted into the merozoites in the liver, and the merozoites then can infect red blood cells. So in the fourth step, these red blood cells are infected with merozoites. Then in the red blood cells, asexual reproduction starts. Merozoites are converted into ring form, then they become trophozoites, and then they become schizonts. And when schizonts rupture, they release merozoites into the circulation again, and this cycle is repeated again and again. So depending on how many time it takes for a plasmodium to complete its cycle, there are different forms, there are different types of plasmodium malaria, noleski, plasmodium falciparum, and plasmodium vivax and ovale. They take different times to complete this cycle, so they will have different patterns of fever and different names of malaria, different types of malaria, and different management. All is based on this asexual reproduction time. Now when merozoites are doing reproduction in the red blood cells, some of the schizonts are converted into gametocytes. Some are converted into gametocytes, male gametocyte and female gametocytes. So when another mosquito bites this infected person and takes up a blood meal, these gametocytes are transmitted to that mosquito. In the gut of the mosquito, these gametocytes are converted into sporozoites again, and then these sporozoites move toward the salivary glands of the mosquito, and then when this mosquito bites another person, they release sporozoites into the circulation. So this cycle is repeated again and again, and this is how plasmodium and malaria is spread. So after briefly discussing about the malaria, briefly discussing about the parasite, vector, and the life cycle, now we deep dive into the clinical features. We divide malaria into two types on the basis of severity. One is known as uncomplicated, other is known as severe malaria. So what are the features which differentiate that this malaria is uncomplicated, and what are the features of severe malaria? So in uncomplicated fever, in uncomplicated malaria, there is a prodrome of headache and fatigue. There is a prodrome phase which is characterized by headache and fatigue. After this prodrome, febrile phase begins. Then comes the febrile phase, which is characterized by high grade fever, chills, and when fever subsides, it is characterized by sweats. So this is the characteristic pattern of uncomplicated malaria. It is characterized by a prodrome phase, headache, fatigue, and then there is febrile phase, which is characterized by high grade fevers along with chills and rigors, and then sweats. Now, as I have told you previously that there are different types of plasmodium which have different time periods which they take to complete their asexual reproduction in the red blood cell. So the pattern of fever will also be different depending upon the plasmodium type. For example, if it's plasmodium knowleski, then fever spike or fever febrile episode will occur every 24 hours, and this is known as quotidian fever. If it's plasmodium malariae, then the fever will occur every 72 hours, and this is known as quatern malaria. And if it's ovale and vivax, then fever occurs every 48 hours, and this is known as tertian malaria. And if there is no pattern of fever, it occurs irregularly, then this is known as plasmodium falciparum, the dangerous one. Plasmodium falciparum, irregular. Remember one thing, between the febrile episodes, the patient appears well. If the fever episodes occurs every 24 hours, this is known as quotidian fever, and it occurs due to plasmodium knowleski. If the febrile episode occurs every 48 hours, it is due to ovale and vivax, and this is known as tertian malaria. And if it occurs every 72 hours, then this is due to plasmodium malariae, and it is known as quatern malaria. And if there is no pattern of fever, it occurs irregularly, then this is due to plasmodium falciparum. So first feature in uncomplicated malaria which you will see is a typical pattern of fever depending upon the type of plasmodium. But remember one thing, these type of patterns are usually not seen clinically, because these patterns will only occur if you leave the disease as such and take and intervene, and don't intervene any medication with any medication or anything. Because when you let the natural disease to progress, you will see these typical pattern. For example, if you take any medication, the fever will subside, and you will not be able to differentiate whether the fever subsided is due to medication effects or whether the fever episode has subsided itself. So that's why, because we are taking medications, everyone knows about Panadol or paracetamol, and they take whenever they have fever. So because of the medication, these episodes are not usually seen clinically. Other features can also be seen, such as hepatosplenomegaly. Your liver can be enlarged and your spleen can be enlarged. So these both organs can also be enlarged. And besides this, you can see severe myalgias, arthralgias, and back pain. So you can see these features in uncomplicated malaria. First is fever, then hepatosplenomegaly can also be seen. Besides this, there could be myalgias, arthralgias, and back pain. Now we come towards the severe malaria. Before going into the clinical features of severe malaria, first of all, we should know why the malaria becomes severe. As I have told you in the life cycle, that merozoites here, these merozoites, they infect red blood cells. These infected red blood cells sometimes can block the capillaries, which can lead to severe organ dysfunction. So let's suppose this is our red blood cell. So this, it is infected with merozoites. So let's suppose this is a capillaries. These infected erythrocytes, they block these capillaries. So they block these capillaries, and this capillary blockage leads to severe organ dysfunction. And these can lead to severe organ dysfunction. So what are the clinical features we see when there is severe organ dysfunction? If one or more than one of these features are present, then this is known as severe malaria. What are those features? Starting from the top, first is CNS. In CNS, you can see hallucinations. You can be confused. Consciousness can be impaired. You can have seizures, and you can have coma, which you refer to as cerebral malaria. So starting from the top, when the organ dysfunction of CNS occurs due to blockage of capillaries by these infected erythrocytes, you can have confusion, hallucinations, impaired consciousness, seizures, and ultimately coma. Then coming down towards the heart. So So when heart is affected, you can have shock or heart failure. It can also be seen in severe malaria. You can have shock or heart failure. Then thirds are your lungs. We are moving from top to bottom to easily remember the detail. Above you have CNS, then in coming towards the chest you have heart and lungs. So when your lungs are affected, you can have ARDS, you can have pulmonary edema, and you can have respiratory distress. So these features can be present in severe malaria if they affect the lungs. Then coming towards GIT, which includes your liver as well as your digestive system. So in GIT you can have jaundice. Presence of jaundice means that the malaria has infected your liver. Then renal. When kidneys are affected, you can have oliguria or hemoglobin uria. You can have AKI, acute kidney injury, and flank pain. So these features are very important to remember. When you are dealing with a patient of malaria, you should rule out whether the malaria is uncomplicated or severe malaria. For that, you have to be very clear about the different organ system dysfunction seen in severe malaria. So we have discussed about CNS, heart, lungs, GIT, renal, and then there is hematopoietic. In hematopoietic, you can have, let's suppose these are your cells. You can have bleeding due to thrombocytopenia, severe bleeding. And then number 7, a general feature of severe malaria is prostration. Prostration means you are feeling so much weak that you are not even able to get up from the bed. So these are the features which suggest severe malaria. So I am repeating once again because these are very important. In CNS, when infected erythrocytes block the capillaries of CNS and leads to the organ dysfunction, we can have hallucinations, confusions, impaired consciousness, seizures, and coma. And when the similar process occurs in the heart, we can have shock and heart failure. And when similar process occurs in the lungs, we can have ARDS, pulmonary edema, and respiratory distress. When similar process occurs in the liver, we can have jaundice. When similar process occurs in the renal, we can have oliguria, hemoglobin uria, AKI, flank pain. When the circulatory cells are affected, we can have severe bleeding, and as a general feeling, we can have severe prostration, means we feel so much weak that we are not even able to get up from the bed. If we see any of these features in the history of the patient, we should be alert that this is going towards the severe malaria. And the management of severe malaria is different from the management of uncomplicated malaria. That's why I'm focusing so much on this. So these are the 7 features based on the organ system. Just remember from top to bottom: CNS, heart, lungs, coming towards the abdomen, where liver, GIT, renal, and then hematological and general. So besides this, there are some lab markers which also suggest that the malaria is severe. So what are those lab findings? Now we will discuss about lab findings. So first is severe anemia. If the HB is less than 7 in adults and less than 5 in children, it is a marker of severe anemia. Because when I have told you in the life cycle that merozoites infect red blood cells, and when these uh, then these schizons are ruptured to release merozoites, RBCs are also ruptured, so hemolysis is going on. That's why there is anemia. If the HB is less than 7 in adults and less than 5 in children, it is a marker of severe malaria. Then hypoglycemia. Hypoglycemia. If your BSR is 40 or less than 40, it is a marker of severe malaria. First is anemia, second is hypoglycemia, then third is acidosis. And what is meant by acidosis? If your base deficit is greater than 8 milliequivalent per liter. What is meant by base deficit? Suppose normal pH is 7.35 to 7.45 and now the patient pH has decreased. So how much base is required to bring back the pH from low acidotic range to normal pH of the blood? So if that base deficit is greater than 8 milliequivalent per liter, means we need 8 milliequivalent per liter of base to bring back the pH of the patient towards the normal, then this is a marker of severe malaria. Or if your bicarbonate is less than 15 milliequivalent per liter. If your bicarbonate is less than 15 milliequivalent per liter or your base deficit is more than 8 milliequivalent per liter, then this is the third marker of severe malaria. First is severe anemia, second is hypoglycemia, third is acidosis, fourth is hyperlactemia. Hyperlactemia means your serum lactate should be greater than 5 milliequivalent per liter. If your serum lactate is more than 5 milliequivalent per liter, then this is also a marker of severe malaria. Then 5. Acute kidney injury. So what are the lab markers of acute kidney injury? Creatinine and urea. If creatinine is greater than 3 milligram per deciliter or urea is greater than 20 millimole per liter, then this is a marker of severe malaria. And number 6, hyperbilirubinemia. Hyperbilirubinemia. If your serum bilirubin is greater than 3 milligram per deciliter, then this is also a marker of severe malaria. And number 7 is high malarial parasite. High malarial parasite. In the blood, if the parasite count is greater than 5% or greater than 2 lakh parasites per mcl, then this is also a marker of severe malaria. So these are the 7 lab markers of severe malaria. There were 7 features of related to organ system dysfunction which suggests severe malaria, and also there are 7 lab markers of severe malaria. So there are total 14 markers of severe malaria. If at least one or more than one of these is present in a patient with confirmed malaria, then this is a severe malaria and it should be treated on the basis of those management principles which are developed for the treatment of severe malaria. So now, after discussing the clinical features, now come towards the lab findings. Investigations. So what are the investigations we should perform in a patient with suspected malaria? First of all, you should do CBC. Since this was the red blood cells and it undergoes hemolysis. I have told you that there is hemolysis going on, so your HB would be less. So first feature which you see on CBC is anemia. You can have anemia on CBC. Then your platelet count, then your platelets are also destroyed, and you can have thrombocytopenia and bleeding. So another feature which you can see on CBC is thrombocytopenia. Then you have your third cells, and these are known as WBCs. These are platelets and these are RBCs. So WBCs are also low. This is known as leukopenia. So you can have anemia, you can have thrombocytopenia, and you can have leukopenia. So first investigation is CBC. Remember, we divide the investigation into two groups. One are general investigations and one are specific investigation. CBC is a general investigation. It is not confirmatory of malaria. It is a general investigation which points towards the malaria. It gives clues towards the diagnosis. So another group of investigations are those which are related to hemolysis. So to understand this, let's draw a cell. So now this is a cell. Suppose this is your RBCs, and when the RBCs membrane is intact, entry into the cell and exit from the cell is very much controlled. And when hemolysis occurs, all the things present inside the cell will come into the circulation. When the RBCs are ruptured, everything present inside the cells will come into the circulation. So what are those things? First is hemoglobin. So we will measure the serum hemoglobin concentration. So when RBCs are ruptured, hemoglobin is released into the circulation. So hemoglobin will come into the circulation. Initially, hemoglobin concentration will increase. So increased hemoglobin in the blood is known as hemoglobinemia, and this increased hemoglobin will come into the kidney and filtered in the urine. So this is known as hemoglobin urea. So initially hemoglobin concentration will increase in the blood and ultimately in the urine. But as the time progresses, because more and more RBCs are being consumed and hemolysis is going on, ultimately hemoglobin concentration will fall. So it can be either increased or decreased depending on the time frame when we are checking. Another thing is known as haptoglobin. First is hemoglobin. Second thing is haptoglobin. So haptoglobin is a molecule which binds hemoglobin in the circulation, which binds free hemoglobin in the circulation. So if more and more hemolysis is going on and more hemoglobin is released into the circulation, then more and more haptoglobin molecules are being consumed to bind the hemoglobin. So the concentration of haptoglobin will fall as a result. Let's suppose this is hemoglobin and this is a molecule of haptoglobin. If more and more hemoglobin is being released into the circulation due to hemolysis, more and more haptoglobin molecules are used to bind that freely released hemoglobin in the circulation. So the concentration of haptoglobin in the circulation will be decreased. So this is another marker that hemolysis is going on. Then we measure serum LDH. serum LDH. Remember LDH is present in high concentration inside the cell. So when the cells are being ruptured, LDH is released into the circulation. So serum LDL will increase. So this is another marker that hemolysis is going on. Then when cells are ruptured, uh, the products are used to make indirect bilirubin. So when there is hemolysis, indirect bilirubin will increase. And when there is hemolysis, if the bone marrow is working fine, it will try to compensate that hemolysis. So when bone marrow is actively multiplying and trying to compensate, we know that the reticulocyte count is increased. So if we measure the reticulocyte count, it will also be increased. So these are the 5 markers which suggest that hemolysis is going on. First is hemoglobin concentration. It can be either increase or decrease. Then haptoglobin, then serum LDH, then indirect bilirubin, and then reticulocyte count. One of the features I told you in the severe malaria was hypoglycemia. So how we have known that there is hypoglycemia in the blood? Obviously, we would measure blood sugar. So third investigation, so we are dividing the investigation into groups. First one was CBC, in which you can see anemia, thrombocytopenia, and leukopenia. You can see anemia, thrombocytopenia, and leukopenia. Then hemoglobin. In all these are the markers of hemolysis. Let me write here investigations which indicate hemolysis. Hemoglobin, then haptoglobin, then serum LDH, indirect bilirubin, and reticulocyte count. These are 5 markers of hemolysis. So third investigation is BSR. It will be low. If the patient has developed severe malaria, if there is uncomplicated malaria, then BSR will be normal. BSR will only be low in severe malaria, but we will check to know whether it's uncomplicated or severe malaria. Fourth is markers of AKI. So we will perform renal function test indicating urea and creatinine. We will measure urea and creatinine. Then we will do ABGs, arterial blood gases. One of the feature lab findings of severe malaria was acidotic and hyperlactatemia. So we will see base deficit, we will see pH, we will see bicarbonate, all those we will see in ABGs. Then we will perform urine complete examination to see hemoglobin urea. I told you when the hemoglobin concentration in the blood is increased, it will come into the urine, and this condition is known as hemoglobin urea. So that's why we will perform urine complete examination to see hemoglobin urea. So these are the 6 general investigations which are performed in a patient with suspected malaria. Now we will see specific investigation. The most important is Giemsa stained thick and thin smear. Giemsa stained thick and thin smear. Thick smear have high sensitivity and thin smear have high specificity. So thick smear will tell you whether the plasmodium is present or not. It answers a simple question, whether the plasmodium is present in the blood or not. And thin smear is performed after confirming the presence of plasmodium with thick smear. Thin smear will tell you the type of plasmodium present in the blood smear. These are different from each other. Thick smear will tell you whether plasmodium is present in the blood or not, and thin smear will tell you which type of plasmodium is present in the blood. Because some of the forms of plasmodium are resistant to some drugs, so we have to be very sure what are the types of plasmodium present in the blood so that we can manage them accordingly. So we perform both thick and thin smear. Another is rapid antigen test using ICT kits. Most of the labs are doing this rapid antigen test by ICT kits. These can also confirm the presence and types of malaria. So these are the investigations which we should perform in a patient with malaria. We divide them into general investigations and we also divide them into specific investigations. There are 6 general investigations and there are 2 specific investigations. Now coming towards the treatment. First, as I have told you that malaria is divided into 2 types on the basis of severity. So first we will discuss about uncomplicated malaria. And remember one thing, complications of malaria only occur with Plasmodium falciparum. All the other forms of Plasmodium cannot cause severe malaria. All the other forms including Nolasky, malaria, Vivax and Ovale, they only cause uncomplicated malaria. And Plasmodium falciparum can cause uncomplicated as well as severe malaria. So if we perform test in a malaria patient and we come to know that the malaria is due to either of these 4, Vivax, Ovale, malaria and Nolasky, then the malaria will be uncomplicated. And how we will manage uncomplicated malaria? Depending on whether there is chloroquine sensitivity or chloroquine resistance. Now there are, let me write here, there are 2 pathways. One is if the Plasmodium is chloroquine sensitive, then obviously the drug of choice will be chloroquine. If the malaria is chloroquine resistant, so first is if the Plasmodium is chloroquine sensitive, then we will give chloroquine 250 mg. How we will give it? Chloroquine 250 mg, loading dose of 1000 mg. So if one tablet is of 250 mg, how many tablets will make 1 gram or 1000 mg? 4 tablets. So we will give loading dose of 4 tablets of chloroquine 250 mg, and after that loading dose we will give 500 mg or 2 tablets at 6 hour, 12 hour and 48 hour. If the Plasmodium is chloroquine sensitive, then we give chloroquine 250 mg, loading dose of 1000 mg or 1 gram, which make 4 tablets, and then after giving loading dose we give 500 mg, meaning 2 tablets at 6 hour, 12 hour and 48 hour. So this is the pathway we follow if the Plasmodium is chloroquine sensitive. What if it is chloroquine resistant? Then obviously we cannot give chloroquine. Then the drug of choice is artemether plus lumefantrine. It comes in different formulation like 20 into 120, 40 into 240 and 80 into 480. Just double, 20 40 हो गए and 40 becomes 80. 120, 240 and 480. These are the three combinations available for artemether lumefantrine. So if the plasmodium is chloroquine resistant, then we give artemether lumefantrine. If we are choosing 40 into 240 combination, then we should give TDS for 3 days. If we are choosing 80 into 480 combination, then it is given in BD for 3 days. So this is how we treat plasmodium which is chloroquine resistant. Remember, let me summarize. We have performed tests and we come to know that the malaria is due to either one of these, Vivax ovale, Malaria knowleski. Then it means it's uncomplicated malaria, because they cannot cause complicated malaria or severe malaria. Plus there are no features of severe malaria, which we have discussed before. No features of severe malaria, and the malaria is either due to one of these, then it's uncomplicated malaria. Then we check whether chloroquine sensitive or chloroquine resistant. These depend on the resistance pattern in different countries of the world. Every country has different resistance prevalence, and there are different guidelines for the malaria in different regions of the world. So there is a general rule: if it's uncomplicated, meaning no features of severe malaria, and it's not meaning no features of severe malaria, then we check whether it's chloroquine sensitive or chloroquine resistant. If it's chloroquine sensitive, then we give chloroquine 250 mg 4 tablets, which make 1 gram loading dose, followed by 2 tablets 500 mg at 6 hour, 12 hour and 24 hour. If the chloroquine is resistant, then we give artemether lumefantrine. These come in different formulations: 20 into 120, 40 into 240 and 80 into 480. If we are choosing 20 into 240, then it is given TDS, meaning this tablet is given 3 times per day for 3 days. If we are choosing 80 into 480 combination, then it is given BD for 3 days. One important feature is so this is your liver. These are your sporozoites. They come into the liver. Here they are converted to merozoites and released into the circulation. Some of the merozoites are converted into hypnozoites, and they remain dormant in the liver, and they are the reason of recurrent relapsing malaria. Only Plasmodium vivax and ovale, they form these hypnozoites and they remain dormant in the liver, and they come out of the dormant stage and they can cause recurrent relapsing malaria. So these chloroquine and artemether and lumefantrine, they will kill only those plasmodium which is present in the circulation. They have no role in killing those malaria, those plasmodium which are present in the liver. So if the malaria is due to vivax and ovale, if it's due to vivax and ovale, then besides giving chloroquine or artemether lumefantrine, we give another drug to kill hypnozoites which are present in the liver, and this is known as primaquine. Primaquine 7.5 mg. Primaquine 7.5 mg, 4 tablets. So 4 tablets will make 30 mg. So we give primaquine 30 mg dose. So one tablet is 7.5 mg and we need 30 mg. So we give 4 tablets, either OD or BD, for 14 days. These are used to kill hypnozoites present in the liver. So another thing is we give paracetamol to control fever. We can give paracetamol 500 mg tablets, either 1 plus 1 plus 1 or 2 plus 2 plus 2. These are and either be given. And third is we give any multivitamin or appetizer along with it. So these are three things. If the malaria is uncomplicated, then we treat in this way. Now, coming toward the second concept. This was the first concept. Now this is again uncomplicated malaria. But this time it's not due to one of these. This time it's not due to one of these. Now this is due to falciparum. And we know that falciparum is resistant to chloroquine. Falciparum is resistant to chloroquine. So we will not follow this pathway. This pathway will not be followed if the uncomplicated malaria is due to falciparum. If the uncomplicated malaria is due to either one of these, then we can go with this pathway if there is chloroquine sensitive. But we already know that falciparum is chloroquine resistant, so we cannot treat uncomplicated falciparum malaria with chloroquine. We can only left with this option, artemether lumefantrine. So the treatment protocol is same. For uncomplicated falciparum malaria, because it is already chloroquine resistant, lumefantrine. Same 40, 240 or 80, 480. These are for TDS for 3 days, then they are BD for 3 days. Again, paracetamol for fever and multivitamin or any appetizer. So this is how we treat uncomplicated malaria. First, I have told you that malaria is of two types depending on the severity, uncomplicated and complicated. So if the uncomplicated malaria is due to either one of these, Vivax, Ovel, malaria and Nolaski, then we can go with either of the two pathways depending upon the chloroquine sensitivity. If this is chloroquine sensitive, we can go with this pathway. If we chloroquine resistant, then we can go with this pathway. And plus, if this is due to Vivax and Novelli, we know that they make hypnozoites which are dormant in the liver and they can cause chronic relapsing recurrent malaria. So we give Primaquine 7.5 mg tablet, 4 tablets which make 30 mg OD or BD for 14 days, plus paracetamol and multivitamin. But if the uncomplicated malaria is due to falciparum, we already know that it is chloroquine resistant, so we cannot go with pathway number 1. We only left with pathway number 2, which is artemether lumefantrine. The rest of the management is same for uncomplicated falciparum malaria. Only thing which you should remember that chloroquine is resistant, the falciparum is resistant to chloroquine. So this is how we manage the patient with uncomplicated malaria. Now coming towards the patient who have severe malaria. I am not going to repeat the criteria which are essential to make the diagnosis. We have already discussed 7 clinical features starting from CNS and 7 lab criteria. If any one or more of those features are present, then this is known as severe malaria. Because there are multiple system organ dysfunctions, so management of severe malaria is slightly different. First of all, severe malaria. So first of all, we will stabilize the patient. Stabilize the patient using A, B, C, D, E approach. Airway, breathing, circulation, disability, exposure. So if you are a doctor, you are already familiar with this. We will manage his airway, breathing, circulation, disability, exposure, all these. We will stabilize the patient using A, B, C, D approach. Second thing, we will establish large bore IV cannula. We will pass IV cannula Third is we will pass NG, Folis and urine bag. We will consider early HDU or ICU admission in severe malaria because it is life threatening. And number 5, we will do vital monitoring. These are general things we can do. We will stabilize the patient using ABCD approach. We will establish large bore IV cannula, and while we are establishing large bore IV cannula, we can take the sample and send the lab investigation, which we have already discussed. Then we can pass NG, Foley's urine bag. We can consider early HDU and ICU admission, and we will do vital monitoring, and we will obtain labs. Then one of the feature I told you in severe malaria was hypoglycemia. So we will give dextrose 5%, 1 liter IV OD, and ringer lactate or normal saline 1 liter IV BD. Because the patient in ICU is mostly NPO, nil per oral, so we will give IV fluids 3, so it is making total of 3 liters. Dextrose 5%, 1 liter IV OD to correct hypoglycemia, and ringer lactate normal saline 1 liter IV BD, so it is total of 3 liter fluid. Then we will give IV anti-malarial. IV anti-malarial, and the drug of choice is artesunate. IV artesunate. What is the recommended dose regimen is 2.4 mg per kg per dose. 2.4 mg per kg per dose IV stat. 2.4 mg per kg per dose IV stat. Then 2.4 mg per kg per dose at 12 hour, and then 24 hour, and then 2.4 mg per kg per dose OD for 2 days, for 2 more days. So this is how we give anti-malaria. The drug of choice in severe malaria is IV artesunate, 2.4 mg per kg per dose at IV stat, then at 12 hours, and then at 24 hours, and then 2.4 mg per kg per dose OD for 2 more days. Then we can give for fever, we can give IV paracetamol, 1 gram IV TDS. We can give IV paracetamol 1 gram IV TDS. Then number 5, we can give antibiotics if there is suspicion of secondary bacterial injection like ceftriaxone 2 gram IV OD for secondary bacterial infection. In ICU there is risk of pressure ulcers, stress induced gastric ulcer, so we can give gastroprotective like injection omeprazole 40 mg IV OD. So if the patient is having seizure, then we can give anti-seizure medication, and that seizure protocol could be followed. If the patient has vomiting, then we can give IV antiemetic like metoclopramide or domperidone. Then mg IV TDS. If the patient has developed AKI, then we can move toward dialysis. So this is how we manage severe malaria. So these are the general management, because there are multiple severe organ system dysfunction, so we will manage each complication. For example, if the patient is having fever, we will manage fever. If the patient is having secondary bacterial infection, we will give antibiotic. If the patient is admitted in the ICU, there is risk of stress induced gastric ulcer, we can give IV and gastroprotective. If the patient is vomiting, we can give antiemetic. If the patient has developed AKI, we can go toward dialysis. Similarly, if the patient is having seizures, we can follow seizure protocol. So we will manage complications. These are not the specific management, these are complication management. So I'm repeating again the management of severe malaria. We will stabilize the patient using ABCD approach. Then we will establish large bore IV cannula, NG Foley's urine bag, HDU ICU admission, vital monitoring, and lab obtained. We will obtain labs. So these are general things. Then to correct hypoglycemia, now we will start the management of complication as well as the management of underlying malaria. So dextrose 5% for hypoglycemia, ringer lactate or normal saline 1 liter IVBD, so total of 3 liter. If the patient is fever, we will give IV paracetamol, IV ceftriaxone for secondary bacterial infection, IV omeprazole for gastroprotection. If the patient is vomiting, we can give antiemetic. If the patient has developed AKI, we can go with dialysis. If the patient is having seizure, we can follow seizure protocol. So all these are the management, general management for complication. The specific management is this: IV anti-malarial, and the drug of choice is IV artesunate. Dose is 2.4 mg per kg per dose, IV stat. Then at 12 hour, 24 hour, and then 2.4 mg per kg per dose OD for 2 more days. So this is how we manage severe malaria in the ICU HDU setting. So if you have any question, you can ask me in the comment section.